Let's get back to C-section. Let's say a woman has a successful C-section. What's the worst, or what are the biggest dangers to a woman and to a child in case of a successful C-section? No one's being hurt, and etc.
Okay, so she has a C-section, and for whatever reason, it doesn't matter whatever reason, she heals fine. The baby did fine.
Yes.
So the baby doesn't have any of those things we talked about earlier, like developing of autoimmune disorders or anything like that. Baby's developing fine. And again, most babies from cesarean sections, because of the strength of our design, will do just fine. And the mother had an incision, had it sewn up, has her skin closed. She didn't get a wound infection. She didn't get a problem at all. So she's fine.
How common are those infections?
What's that?
How common are those infections?
Well, skin infections are not uncommon, especially in women who've had a long labor and then have a C-section. They're not serious. The wound can open up a little bit. It just requires some time, and it will close by what's called secondary intention. And it's annoying, and it's a problem, but it's not major. So you're saying a woman that gets through a C-section and she's perfectly fine?
Yeah.
Okay.
That day, she's perfectly fine that day.
Okay. So she has to recover from that. So that's a major surgery, major abdominal surgery. You've cut through the muscles, they cut through the uterus. So it's going to take 6 to 8 weeks to really recover most of those muscle functions, most of those things. So during that time, things are a little bit slower. If she has 2 or 3 other kids at home and now a newborn baby, that's going to be a little bit harder for her. Okay. She could have more blood loss. I mean, you can have more blood loss from a vaginal delivery too, but she could have more blood loss, so she's going to be anemic. That's going to be slightly make her recovery a little bit slower. Again, she will recover. They will do fine. I mean, cesarean surgery is major abdominal surgery, but obviously doctors are very good at it, probably because they do it all the time. Mm-hmm. You get very good at it, but it's not without its potential complications, and those are mostly will be seen downstream. So when you do a major abdominal surgery on someone, and they've healed perfectly, and now 6 weeks has gone by, and they're back at full activity, they're driving their car, they're picking up their kids, they're doing all the things that they're normally doing, their periods come back eventually, their breastfeeding went without a hitch, we're just talking about that normal. So what is the downside of a cesarean section? Well, one of the first things that I have learned is that doctors do not believe cesarean sections have downside risks. Mm-hmm. Why do I say that? I'll say that because as a breech practitioner for most of my career, especially when I left the hospital and was doing them at home, and people would come to me for an interview, they'd be 38, 39 weeks pregnant. They're in a tiz because now they're breech and the only option they're being offered is a cesarean section. They come to me and they'd tell their history, and I would talk to them and I'd look at them, my baby on ultrasound, and I'd say, you meet all the criteria for a safe attempted vaginal delivery for breech birth. But one of the questions I would ask them is the doctor who told you had to have a C-section for this baby, your first baby, did they ever ask you if you want more children? And the answer is universally no. The doctor's never asked because the doctor isn't concerned about what happens to this woman down the road. Mm-hmm. His concern is that he thinks that a C-section is safer for this baby, and therefore it's the right thing to offer without ever looking downstream. Again, a bit of stage 1 thinking. If I do a C-section for this baby, don't ask the follow-up question, and then what happens? Mm-hmm. But now you've got a woman who's got what's called a scarred uterus. And she may live in a community that is very VBAC unfriendly, vaginal birth after cesarean unfriendly. And they may say to her initially, well, if you have this C-section, you can VBAC with your next baby. But then you're pregnant with your next baby, and you find that the language and the subtle coercion is such that they're telling you that it's dangerous and we don't support it. And so now you've got that stress to deal with, right? You also have the risk of complications that can occur from a surgery that don't show up right away, like scar tissue, adhesions, bowel obstruction. Those things can happen months or years later after you've had any major abdominal surgery. So they're always in the background, mm-hmm. right? Now, you're pregnant with a second baby.
Yes.
If you get pregnant too soon, like in less than 6 months from the time you deliver your other baby, they're going to tell you that the risk of rupturing your uterus is so high that you should have a repeat C-section. That also is false. It's higher, but a higher chance does not mean high risk. And ultimately, the decision about how to proceed should belong to the adequately informed woman. And in order to adequately inform a woman, you need to tell them actual risks, not relative risk. Relative risk is completely different than actual risk. So let me explain that for a second. We'll get back to the... if something happened in California one time last year, the actual risk is 1 in 40 million. Everybody agree we have 40 million people, which is crazy, by the way, that California has 40 million people. I was talking to somebody in Canada yesterday, and I said, yeah, we have more people than Canada in our state. Canada has like 33 million people. Yeah. So 1 in 40 million. Now, say this year it happens 10 times. Disease X happens 10 times instead of 1 time. Somebody who's trying to promote funding for disease X is going to go to Sacramento and is going to say, there's been a 10-fold increase in disease X.
From 1 to 10.
Right. But the actual risk is still 1 in 4 million.
Correct.
Okay. So is 1 in 4 million any significantly different to you, Apollo, than 1 in 40 million? No, they're both 0.
Correct.
Yeah. I mean, if you round it to the nearest number, it's 0. It's still 0.
It's still 0.
Right? Yet, if you want to use your bias to promote doing something, you'll use that. So that's the difference between relative risk and actual risk. And I would suggest to your listeners that a lot of their obstetricians know relative risk, but they have no idea what the actual risk is. Mm-hmm. So you're going to be taught if you've had a C-section that you have to wait at least, they'll say 18 months before you get pregnant again. And if you get pregnant before that, they're going to tell you need a C-section. They read an article once that said that. They've never looked any further into the research. They don't understand about giving information so the woman has the right to make informed consent. They think that they are doing good, but they've lost something in their ethics has been off tilt, because ultimately that is not their responsibility. Their responsibility in informed consent is there are three phases of informed consent. One is to give objective information. So the doctor gives his information what he thinks. Excuse me. Objective is not what he thinks. Objective is what the information shows.
Based on something.
Right. Then then it's the doctor, because he's an expert, has the right to give his subjective opinion. You know, the data on breech birth shows that breech birth can be successful in the right hands, but I've had bad experiences with that, or I don't think it's a good idea. Okay, that's legitimate. Mm-hmm. But the third phase is called support. And if the woman says, I hear what you're saying, but I think I want to go for a vaginal breech birth, or I want to go for a VBAC,
the doctor should support
the doctor should support that. Now, support can look many ways. It could say that, sure, I'm in with you. Or an honest doctor would say, I support your right for a VBAC, but my hospital doesn't allow it. So you need to look elsewhere you need to look to another hospital. Or I support your right for a breech delivery. I think the literature does support properly selected breech and skilled hands. I don't have skilled hands. So why don't you call up Dr. So-and-so at...
They will never do that.
But they don't do that. Correct.
They will lose money.
Ego and money.
Ego. Come on. Ego? We're talking about people's lives. Ego?
Well, doctors are known for having very large egos.
Playing God?
Yeah. I mean, there is still that. And by the way, when you have life in your hands, sometimes it does start to become something you have to keep reining in, that you're not that person. But ultimately, medical ethics dictates that the decisionally capable woman has the right to make any decision she wants. She has the right to informed consent. She has the right to informed refusal. She has the right to uninformed refusal. She could say something like, I want to do this. And the doctor says, well, let me tell you why that's not a good idea. I don't want to know. I'm just doing this. And we ethically are supposed to support them. We're not supposed to call Child Protective Services. We're not supposed to coerce them. We're not supposed to threaten them.
Because people are not slaves anymore.
Not in America. I mean, there are other countries where you don't have the same Bill of Rights and things that we have here. But in America, you have the right to say no. And yet women have been bullied to think that they don't. And that bullying is going on over and over and over again. So you have that risk when you have that C-section of having that argument coming down the road. You also, once you've had one C-section, your risk of something called abnormal placentation, better known as something like placenta accreta or placenta previa, where the placenta presents covering the cervix or the placenta grows into the uterine wall,
No.
far more likely to occur after you've had a C-section. It's not very likely, even then, but it's more likely than a woman who's never had a scarred uterus is very unlikely to have those things. Once you have one C-section, it's higher. If you have a second C-section, it's higher than that. If you have a third C-section, it starts to get relatively significant.
2 digits, percentage-wise?
By after your third C-section is close to 2 digits, yeah. It's close to 10% probably. And nobody tells them that. And nobody tells the woman who has that first C-section for breech. Nobody asked her that. They said, I mean, she may want 7 children.
Mm-hmm.
And now you've put every one of the next 6 children at greater risk than you would have by letting that woman have a vaginal labor with a breech baby with somebody who knew what they were doing. And this is considered the good practice of medicine. And what I did was supporting breech delivery in the home setting or even in the... My privileges were not renewed because I refused to comply with the request that I stop doing breech delivery in the hospital.
You got a request from management?
From the OB department and the medical executive committee. Because we were making the anesthesiologists and the pediatricians and the labor and delivery nurses nervous. Because all they had known for all the years before I came there was that breech is dangerous, have a C-section, and all the OBs, that's all they did. And when I came in, I brought in different set of skills, sort of a different set of chutzpah, if you understand, that's a Yiddish word for maybe boldness, that I was well trained to take care of these things. I was lucky. I was still trained in an era where breech was considered just a variation of normal. Mm-hmm. We can digress for a second. I went to medical school at the University of Minnesota, and one of those sliding door moments in your life, and people have them, sometimes you don't know them, but this is one where you actually can witness it, is on the 3rd Wednesday of March in the 4th year of medical school, you get an envelope that tells you you've been interviewing for residency programs at different places, and they rate you and you rate them, and it all goes into a computer, and it's called the match. And on that Wednesday, you get an envelope that tells you where you're going to be spending your next 4 years. And I matched in Southern California. So if I had matched in Iowa or Colorado, which were some of my other choices, I can't imagine how different my life would have been than end up going to California and spending up 40 years in California. But I matched in California at Cedars-Sinai Medical Center in Los Angeles, which is a very prestigious hospital. They do good work there. They do stupid things there too, but they do good work there. And as part of the residency program, we were affiliated with, at that time, with LA County, which is Los Angeles County, USC, which is University of Southern California Women's Hospital, LA County USC Women's Hospital, which in 1982, 83, 84, 85 was the busiest hospital in the United States. They were doing about 22,000 births a year there.
In the whole country, the busiest.
The busiest hospital in the United States, 22,000 births a year, which is, Apollo, 65 babies a day.
Yeah, a day.
65 babies a day. I was there for 4 months, every other day. So that's 60 days, 65 babies a day. You can do the math. Now, if breech babies are 3 to 4% of all babies born, then you can, with 65 babies a day, I'm seeing 2 to 3 breeches every day. Mm-hmm. And I'm seeing 1 or 2 sets of twins every day. And so it became something that was routine. And more than it was routine, it was something that we as OB residents loved to do because it made us feel like we were doing something. Catching a vaginal delivery was fun, but it was like boring after a while. But doing a breech baby, doing twins was exciting. And in those days, we didn't do passive. We didn't do all fours, passive waiting, watching. Everything was active. Once we could get our hands on a baby, we'd pull the baby out. We'd do those. So we got very good at things like breech extraction, putting on forceps, vacuums, things like that. You can't do that stuff anymore, and that's probably for the better overall for humanity. But this was more like just volume. We were inundated. Most of the women were illegal. Most of them didn't speak any English. And we just took care of them, and it was an assembly line, and we moved them in and we moved them out because we only had 24 beds and we were doing 65 babies a day. So you can figure out, the craziness that was County Hospital in those days. But I got very well trained.
What was your successful rate?
Oh, I have no idea. As a resident, you don't keep track.
No, no. As a doctor, for in your 28 years career, what was the success rate?
You know, another thing, doctors don't keep track either. I didn't keep track of my numbers. It was not something I did. Only began to keep track of my numbers when I went in and started doing home birthing, and I started following what the midwives were doing, and I kept a logbook. And in those days, the logbook was handwritten. I kept a handwritten logbook of over the 400 and some deliveries that I did in the home setting over 12 years. I have every one of them charted. Of all the deliveries I did over the 28 years in the hospital, I have no idea.
Out of your 400 deliveries at home, how many of the women went to the hospital eventually?
My transport rate was about 7%.
Transport rate is when women go to the hospital because something goes wrong.
So about 93% of women who started at home ended up delivering at home. And about 7% went. And again, it was much higher. It was probably about 10 to 12% of first-time moms and about 1% of second-time moms.
Only 1%?
Yeah. Oh, second-time moms are, if you ask any birth practitioner, you know, if you get a new client and she happens to have already had a vaginal delivery, we're thrilled. Because
they know
we call those are very likely to have what's called a butter birth, which is like, oh, baby's just going to slip and slide right out, and it's going to be easy, and we're not going to be there that long, stuff like that. First time labors are longer, but that's where I got my training in breech delivery, and I did breech for most of my career. I think there was a period of time after the year 2000 when hospitals became very anti-breech delivery. And for reasons that are still, to me, illogical to this time, that they cherry-picked certain few articles that suggested cesarean section was safer for breech than vaginal delivery. And they chose to do that. I believe they chose to do that not because it was safer, but because it was economically and expediently more beneficial to the hospital setting. So in other words, the science proved what the hospital wanted, because there was plenty of science that proved that vaginal breech delivery is certainly reasonable and better for mom and baby, and they ignored that data. So in the year 2000, breech delivery essentially stopped being taught in residency programs anymore. And so for the last 25 years, young doctors coming out of training are not skilled in that, and they are now the bulk of the people out there practicing, which is why it's so hard for a woman who has a breech baby to find any choices anymore.
Breech babies percentage-wise, how common?
3 to 4% at term.
3 to 4. Okay. What's the worst that can happen during the breech?
Same thing. Worst thing that can happen to a head-down baby. You could have an intrapartum fetal demise. You could get a baby. The scare is that the baby's head could get stuck or the umbilical cord could prolapse, and you're not going to be able to get the baby out in time. But again, if I want to scare little kids at a campfire, it's pretty easy to tell a scary story. That's what this is. Because this is not what normally happens. And certainly when you have the proper skills, these things are very rare. Again, I'm a testament. And I'm just one of many, many people who are my colleagues, many of which who are my mentors. I walk on their coattails because they taught me things. After I finished my training, I learned from so many people. I don't want to start naming people because that'll leave somebody out. But they know who they are. And I still work with some of them to this day in trying to advocate for these sorts of things. We go around the world and we teach these skills. I try to keep them alive because midwives are very interested in knowing how to help their clients do with breech and twins, whereas obstetricians are very obtuse and are not interested. And that's what's amazing to me is that they don't want to learn the skill, and then they want to lobby legislators to prevent midwives from being able to practice the skill so that all these women are forced to have C-sections. And if I can tell you that over 90% of my breech babies delivered vaginally, and if a doctor sections 100% of breeches, then you could logically make the argument that 90% of his C-sections were unnecessary.
Unnecessary.
Right. But he will never say they're unnecessary. And he will never accept the consequences of what happens downstream. If you want, I don't know if you can edit this if you want, but I can give you a sort of a horrible example.
No, please.
Okay. So there was a story of a mother and a baby in Arizona a couple years ago who had a uterine rupture in labor at home, and ended up she passed away and the baby passed away.
Oh.
Now, this is her story is she's had a C-section for first baby. Second baby, she'd had a successful VBAC at home. And this was her second VBAC or her third baby at home.
VBAC is
vaginal birth after cesarean.
C-section.
Yeah. And so there are some issues of whether or not the midwife was on top of things and the midwife might have been negligent and whatever. Doesn't really matter at this point. But all the investigatory bodies, the medical board in Arizona, the police in Arizona, the press in Arizona, they were all over this midwife for not managing this properly. I don't know if that's true or not. I've never had a chance. I don't want to ever pass judgment on that. But I know one thing for certain. I never saw anywhere in the press or in the records or in the medical board issues anyone asked the obvious question that was to me the first question that I looked at when I looked at this story. And that was, why did she have her first C-section?
Yeah, but that's history. She already had it. That's it.
No, but why did she have it? She had it because she had a breech baby. And she was not offered a vaginal delivery. So had she been offered a vaginal delivery with her first baby and had a vaginal delivery, she never would have had a ruptured uterus in her third pregnancy and passed away and lost her baby.
Yeah, but maybe she regretted after doing the C-section. Then she had her second child vaginally, and then the third child.
Right, but I think what you're missing my point is that do you think the doctor that did her C-section for breech even knows that she's dead? Do you think that the doctor takes any culpability in the fact that she had a ruptured uterus and dies? Because he did not offer her a very reasonable choice. He skewed his counseling, or she, could have been she. They skewed their counseling to funnel her into something that she probably didn't need that ultimately led to a problem. The reason I point this out is not to be specific in this case. It's just to say that when you mess with Mother Nature, there are downstream consequences. And in this case, the ultimate downstream consequence occurred. Right? Does uterine rupture occur in a woman who's never had a C-section? Yeah. But it's like 1 in 8,000, 1 in 10,000 pregnancies. It's not something that you'd even blink an eye at.
0.1%.
Well, 0.00, yeah, something like that. It's extremely small.
In 10,000, yeah, it's 0.001,
0.001, I think. 001. No, 0.1,
0.01, correct.
0.01. Right, okay, 0.01. So 99.99% chance it's not going to happen. Right. That's normal. So when you asked about what are the downstream consequences of a woman who has a perfect C-section. And this is potentially one of them. Is that there are downstream consequences to her. And then there's a potentially of scar tissue, as I mentioned, which can cause fertility issues. There's all the extra testing that might go on because now she's a VBAC and the extra fear that might be laid upon her in future pregnancies, depending on which practice she's with and who she's with. So it's not without, C-sections are not innocuous. That's my point.